So I'm Nicolas Girard. I'm a thoracic oncologist working at Institut Curie in Paris. So PALOMA-2 is a study that is assessing Amivantamab, which is a bispecific EGFR-MET antibody with cell-directing activity. Amivantamab has been evaluated in patients with EGFR-mutant non-small cell lung cancer, and here we are focusing on the common mutation, 90% of the EGFR mutations. We have a new standard of care in this patient population, which is a MARIPOSA regimen, which is a combination of Amivantamab plus lazertinib, which is a third-generation TKI. MARIPOSA improves the PFS in patients with this disease in the first-line setting as compared to the previous standard of care, which is osimertinib as a single agent, a third-generation TKI. So MARIPOSA is a positive study. It's a combination of Amivantamab plus lazertinib. Amivantamab historically is delivered intravenously. The dose is 1050 milligrams weekly for the first 4 injections, and then every 2 weeks. Here in PALOMA-2, we are looking at subcutaneous injection of Amivantamab, so it's a different formulation for this drug. It's delivered at 1600 milligrams with the same dosing schedule. In the cohort that I reported at ASCO, the patients are the same patients as those enrolled in MARIPOSA, so first-line treatment for common EGFR mutations, and we have Amivantamab subcutaneous plus lazertinib in those cohorts. Those cohorts also implement the prevention for venous thromboembolism, which is frequent in those patients. So what are the results? We have response rate results that are in line with those reported in MARIPOSA. It is above 75%, so a vast majority of patients will show response on the target lesions. We do not have yet the survival outcomes in this study, but the duration, the median duration of response is not reached at the time of follow-up of this cohort of patients. What is very interesting with Amivantamab subcutaneous is not only the fact that it's easier for the patient and the hospital organization, let's say, it is also associated with a lower risk of adverse events, and this mostly includes administration-related reaction. With the Amivantamab intravenous formulation, it's a high risk. It's 60% of the patients historically in the studies, and with the subcutaneous formulation, it's 15%. So we are reducing the risk for these administration-related reaction. We also now have a better protocol to have a prophylaxis of these events with steroids, antihistaminics, and sufficient hydration of the patients. We also see a decrease in the risk of VTE event, which is linked with the administration of prophylactic anticoagulants. So very interesting data. These are in line with those reported with PALOMA-3, again with Amivantamab subcutaneous, but in the late line setting for the same patient population after osimertinib, after chemotherapy. The pharmacokinetic in PALOMA-3 is similar between the two formulations, and we have even a signal of a higher efficacy. So what are the next steps? Well, now MARIPOSA is being implemented as a new standard of care for the first-line treatment of patients, and the subcutaneous formulation for Amivantamab helps in terms of organization and quality of life of the patient, because subcutaneous can be delivered not only as a hospital very quickly, it's more rapid hospitalization as compared to intravenous formulation, so better quality of life of the patient, reduction in the risk of adverse events, so it facilitates everything.